up when it's time to go.
Great.
Take it away when you're ready, sir.
All right. Thank you all for joining us for today's Operations Committee meeting. We're gonna just start with a tech check. Katie, are we all hooked in?
This is just a reminder now. I know that you guys pretty much have the hang of it now. But just if you are able to keep your camera on, please do, but it's okay if you can't. And then just remember to stay muted unless you would like to provide a comment or a question, at which time please click raise hand and then you'll be called upon. We do have members of the public joining us. They're not able to participate, but they are able to view. And this meeting is recorded and will be posted to the website. So with that, unless you have any technical issues, feel free to reach out to me, but I'm just going to go ahead and go right into roll call.
Perfect.
So we'll start with Bruce Goldberg.
Present.
Anne Lovejoy.
Present.
Doug Flo.
Present.
Laura Byerly. Paul Stanville.
Present.
Rosie Lindsay. Michael Horry. Doris Karagu.
Present.
Sarah Bausch. Paula Weldon.
Present.
And Lori Hoagland.
Present.
Wonderful. Thank you very much. I'll turn it back to you, Chair Goldberg.
Great, thanks. Welcome, everybody. Glad you're all here. We have a busy agenda for today. We're going to really do three key things. One, we're going to, and hopefully everybody has gotten the materials in advance and had an opportunity to look through them, because we're going to review and approve our public corporation proposal. You all should have gotten a draft with everybody's feedback included, and we'll go through that. We're going to have a presentation on federal waivers from our great consultants, Anya and Janine. And then we're going to look at and discuss a draft federal waiver report. Those are the big items on our agenda for today. So with that, and if there aren't any questions, Jenny's going to walk us through the public corporation proposal and the edits and changes that were made to that.
And Ginny, if you would like me to pull up the actual document, I'm happy to.
Yeah, that would be great, Katie. Thank you. And thanks,
Great,
Bruce.
It'll be just one moment, but you can get started.
Sure. So we sent out the proposal that we looked over at the last meeting to everyone for their review and sort of, I think, to absorb all of the information that was in there. And I made the changes that were discussed during the last meeting. So those changes were an addition of an executive summary, addition of a recommendation to the board to seek legal counsel when drafting the statute creating a public corporation, and the option not to include any of the specific statutes that were listed in the original proposal. So that's the version that I sent out with those changes. We only got feedback from 2 people saying that they felt that it represented what the changes they had requested were and that it looked fine with them. And I just want to check in with everyone now you had some time to absorb it to see if there are any additional changes anyone would like to make to the document. Or any questions, thoughts, really any input that you'd like to give.
This may seem to be a kind of a minute issue, perhaps, but will there be bylaws for this organization?
Yes, there will be. I mean, what we're recommending is that there be a public corporation, and that public corporation will indeed be guided by a set of bylaws, which will need to be drafted.
And another small question, but is it assumed that going forward that the current board will, which would make sense, would initiate that membership?
That is a question that has come up at the board meeting, wondering about the current board versus becoming the board of the public corporation, or there being a different board. I think that's a question that will come to this group later on, but that's a question we will need to answer.
Okay. And that would include, the bylaws would include components like term limits.
Correct? Term limits, committees, quorums, et cetera.
Okay. Okay. Thank you.
Paul?
Yeah, I didn't actually end up sending feedback directly to you, but they're very small modifications, but the additions in the multiple sections of in consultation with legal counsel and continuing to explore, that perfectly hits the language I was concerned about, like what level am I contributing legal expertise versus, yeah, so perfect. Thank you for those edits. It looks good to me.
Great, thanks, Paul. Does anyone want us to maybe, Katie, maybe you could scroll to the language that Paul was referencing and give everybody a chance to take a look at that. If you go to the bottom of page 4, I think that's the first instance where that language is incorporated, just so that everybody has a second chance to take a look. Yeah. Thanks, Katie.
May I ask who is or who will be the legal counsel?
Legal
think that-
counsel will be the Department of Justice initially.
Okay.
Did anyone have any recommendations or input about whether or not you wanted to keep the specific citations in, or if we should just go ahead and pull all of those out and just leave the recommendation with the language and with the suggestion of having counsel look at that? Or would you like to keep that language in there so there's maybe an example of what kind of language is in other public corporations? Anne?
And you're on mute.
Yeah, I think it would be fine in an appendix. I don't think it's necessary to be in the body of the recommendation.
Does anyone else support that idea, have a differing opinion about the inclusion of the statutes? I can definitely move it all into an appendix when we bring it to the board.
I would agree with Anne's recommendation.
I would agree.
Okay. Okay, I will accept the changes within the document that I've made and that everybody's reviewed, and then add an appendix and take out that last section with all of the statutes in it as an appendix A. I'll send that out to all of you, but we will take it to the board in the next board meeting, and it'll be part of board materials. So it'll be posted about a week ahead of the board meeting. Is
everybody comfortable with that? If not, let us know.
Yeah.
Bruce, at an earlier meeting, you mentioned that this is, at a board meeting actually, you mentioned that this should be viewed as an iterative process. And I think that is still holds true to go forward right now.
Yeah, thanks, Doug. And that's apropos of understanding, we need to clarify the board and the transition from current board to future board.
Okay. Thank you all for the work on the document and for all of your input and in this meeting and the last meeting. So I'll move that forward. Okay, Bruce, back to you.
Okay, so now we're going to get to the meat of our meeting today, which is federal waivers. And before we get into the presentation from Janine and Anya, I just wanted to give a little bit of context from the board. That the board has asked us to look at this operating under the assumption that we're going to need to get federal waivers to include Medicaid, Medicare, all of the public programs. And that at this point, we're not making a decision about which to include, which not to include, but that we're operating under the assumption we're going to need all of the waivers. We're also not putting together a plan B at this point. What do we do if we don't? So we're looking at this as going forward, we're going to need all of the potential waivers to be able to operate the current public programs within the purview of the Universal Health Plan. So it's with that we're going to be looking at this today. It's really, I think, background for the committee and will be useful as we move forward with decisions. So, with that, I'm going to turn things over to Janine and to Anya.
Thanks, Bruce. So I'm Janine Smith from the Portland office of the Health Management Associates, and I'm joined today with Anya Wallach from our from the East Coast offices and her experiences in Vermont. We are going to give you kind of the broad overview, as Bruce said, of waivers. First slide, Katie, please. So why do you need waivers? There's federal law that governs a lot of the public programs, including Medicare, Medicaid. You'll often see a mention of a CHIP, which is the Children's Health Insurance Plan. It's kind of embedded in our Oregon Health Plan Medicaid program. In some states, it's a separate program onto itself. Some of the rules and regulations around ERISA, which you have, I think, talked about, or at least the board has. And then state-based health insurance exchanges and the premium tax credits afforded under the Affordable Care Act. If you want to,
So I'm going to be like this is like the Keenan and Key kind of thing. I'm going to say that means at the state level, you have very little control over a lot of aspects of healthcare coverage because the federal government governs all of those things that Janine just said.
and so if you want to do something different than the way they are set up, you have to ask for a waiver from federal statute. So that's why they're called waivers. There has been a pretty well-known process. Bruce and Anya, in her role as Rhode Island's Medicaid director, have gone through waivers for how we shape our Oregon version of the Medicaid program, our CHIP, and the state health-based insurance exchanges. No state has received a waiver to divert the premium tax credits, although we'll get into a little bit of some of the tweaks that Oregon has been successful at. There have not been broad waiver, and there's no language in the statutes to allow for Medicare waivers, but there are allowances for some limited demonstration projects, and we'll get into that. And then as per your discussions around ERISA, the waivers have not been allowed under that, and we'll get into just a brief overview to remind you about that. Next slide.
And again, I'll interject to say, think of all these funding streams into the current system. So Medicaid, Medicare, private insurance that's regulated, private insurance that isn't. There's very little of that we control. And so part of what we're trying to figure out is how much of that can we assume in the financing of a universal program for math for Oregon. And it varies. So a lot of what we're going to talk about from now on is how does that vary? What are the actual parameters around that? It gets very complicated. It sounds like a simple thing, like, okay, great, we're just going to replace Medicare, Medicaid, private insurance with this, but it's actually super complicated.
So, so there's a certain section of the Social Security Act called Section 1115 that allows some waiver or adjustments to the Medicaid programs. That's a joint venture between the states and the feds. And they allow pilot projects, which Oregon has taken advantage of by expanding eligibility, expanding services, and adjusting how service is delivered to improve care, efficiency, and reduce costs. These waivers are usually allowed for about 5 years, and then you have to go back into negotiations and decide if you're going to renew it, if you're going to change it. At any rate, you have to prove that you're what is called budget neutrality, which is complex to calculate, but it basically is that the federal government isn't going to be paying more for the same number of people and benefits as if there wasn't a waiver. So they don't want to be on the hook for more dollars. And then there's another aspect of it called the maintenance of effort, and that's to not reduce the state's spend or covered population with these new approaches. So those are a couple of things you have to show the feds to be able to get the waiver to go through. And you also have to evaluate it and show whether the demonstration was successful. Next slide. So Oregon's had a demonstration waiver back since 1994. Started our Oregon Health Plan, as it was termed at the time and still is. It's been renewed, amended multiple times. We are in the midst of a current waiver 5-year period that ends September 2027. The new approaches that came into this waiver is allowing children to be covered under the Medicaid program from birth to age 6. The health-related social needs benefits that you've most likely all heard about, but in terms of supporting needs around housing, food, other social needs for specific populations has been approved through our waiver. Increased support through age 25 for young adults with special healthcare needs, expanding and participating fully in the early periodic screening, diagnosis, and treatment coverage, which allows a lot of evaluation and assistance to children to ensure that they grow up healthy. So there's some family caregiver assistance activities under the waiver, and to allow elders to be independent, and OHP benefits for people leaving incarceration. This aspect has not yet been fully implemented, but is due to start. Next slide. We also have some other waivers to another section of the Social Security Act, which is called Section 1915. There's various ones of these. I have them outlined here, but they also would need to be adjusted or looked at to see whether you would need that sort of authority to do things under the universal health plan. But the first one allows for managed care approaches instead of traditional fee for service. This one, a lot of states have, and we've had it for some time. And whether this is applicable depends on how you fully build out your universal health plan design. And then 1915 B's and C's, a lot of alphabet soup here, but it allows for home and community-based services to certain groups of enrollees. So this is more on sort of the disability side, with individuals with intellectual and developmental disabilities, seniors with physical disabilities, and children with exceptional needs or medically fragile. So very specific populations. Next slide. And then that moves us to the Medicare waivers, which I think, Anya, is where you pick up.
Sure. Thanks, Janine. Good setup. So Medicare waivers are much more restricted in a certain sense than Medicaid. In Medicaid, there's this allowance for an 1115 waiver, which is pretty broad and has been applied pretty broadly in terms of what's been allowed to expand either services or covered populations within a waiver. Medicare's authority for allowing deviations from the norm, and the norm is there's Medicare ABC. You either are an enrollee in Medicare A and B as a so-called fee-for-service enrollee, or you're in Medicare C, which is managed care. Aside from that, there hasn't been allowance for a whole lot of experimentation. And so that's a real constraint on what we can do that's innovative in this space. There was under the Affordable Care Act, there was a new authority created through the Centers for Medicare and Medicaid Innovation to allow for some demonstrations around Medicare and Medicaid that otherwise would not have been available. But the bottom line is there's not a whole lot available. And so I'm going to talk about some of the things that are or are not permissible. And Lori, I see you have your hand up.
So when we have expanded coverage to the undocumented adult populations, what waiver is that?
That would be under Medicaid, not Medicare.
Okay, and that also will be in effect till 2027?
Yes, but it's
Depends
also
on the current administration.
it's state dollars. It's
Yeah.
not federal dollars.
We didn't need a waiver for it because of that. It's totally paid with state dollars.
Yeah. And so if the state wants to continue paying for that, presumably that'll still be allowed, but that's up in the air also with the current federal regime. And I don't know, there was something else I was going to say, but I forgot. Okay. So, in terms of Medicare waivers, there's very limited ability. So Medicare is the program that covers people who are either over 65 or under 65 and prove that they have a major disability. And in some cases that's overlap. So you have people who are over 65 with a disability, or 65 with a very low income. So people can be dually eligible for Medicaid and Medicare because they're not only over 65, but they meet some categorical eligibility requirement for Medicaid, and so they can be dually eligible. Anyway, the authority to waive Medicare law and regulation is very limited. To deviate from Medicare statute requires congressional approval, and there are a few examples of that. The most relevant to this exercise are probably the
It's
Maryland
I think
model,
the next slide has that on there if you want to move.
which was authorized under federal law and allowed for a multi-payer, all-payer rate setting kind of cost containment system in Maryland, and also a Hawaii waiver under ERISA that allowed them to mandate that employers must provide 50% of the cost of, must pay 50% of the cost of insurance for their employees. Recent examples of Medicare waivers, which means waivers from those federal laws that are pretty strict, are Maryland and Vermont entered into multi-payer, all-payer model demonstrations where they agreed to a cap on total costs of care increases for the state. And some things under the hood, but basically that was what they did. They said, we will agree that we will keep costs under this level and therefore save Medicare money and therefore give us the flexibility to do what we want with Medicare money. Those models have largely been sunsetted, and now the Maryland model will continue for a number of years. The Vermont model will close down in 2026, and the only new option to states for innovation around Medicare payment is the AHEAD model, which is described here, and it's basically a global budgeting model where a state says, I will agree that we will globally budget for hospitals, which is not entirely well defined. And it's a voluntary model, so they have to the states have to rely on hospitals to sign up for this, and it's not clear how many hospitals within each state will sign up for that. Next slide, please.
And I would just add that currently is kind of for some direct conversations with a CMMI official, that really is the only way to pull Medicare funding in, that the state has an option to do. They've had awarded 3 different rounds to date. Some are just barely getting started in doing their model. They get about 10 million, quite a bit, $12 million over 10 years to do it. But Oregon did not apply for this, and they're not sure if and when there'll be a next round as an option to bring Oregon into it.
Good points. Thanks. All right, I'm going to hand it off to Janine for the next slide.
So the Affordable Care Act, there's a waiver option in that. It's called Section 1332. Lots of states have used it to change a little bit how they run their exchanges for health insurance, but they still have to demonstrate that they're covering the participants as they would under the original way. The need to still be protecting that cost sharing is affordable, and it again not show that there's any increase in the federal contribution than there would be if you follow the rules regularly. Oregon has applied this approach in order to get permission to pull some of the premium subsidy dollars into the OHP Bridge Plan, which was just launched a few months, 6 months ago, I believe, to provide coverage for adults with incomes just above the Oregon Health Plan Medicaid limit, and it allows them and it's structured in such a way they can stay with their OHP CCO and keep the same providers, and then if they then move on out to the regular insurance market if they go up the income ladder. So we have successfully applied that to bring in some funding for this. We're not sure what the future of the premium subsidies are because they are up for reauthorization federally. So this is something also needs to be watched as the federal changes approach us. Next slide. And then Anya, did you want to talk? I think we already mentioned the ERISA exemption. It sets standards for employer-sponsored health plans. I think there's been a memo written very extensively on this for the task force earlier, and you've had, I know the board's had a conversation about it. And as Anya mentioned, only Hawaii has a ERISA exemption related to expecting the employers to do something different. And there hasn't been hasn't been any other states that have been successful at that. And it requires a certain amount of employer contribution. It kind of dictates that they would provide benefits. And Anya, I don't know if you want to add anything on this one. Most discussions have been more about how to avoid running afoul of ERISA.
It's just ERISA is a huge constraint, and I know we hear from national policy experts who say, you know, you could do this, you could do that, but everything you can do that would run up against ERISA is subject to legal challenge, and states have not been particularly successful in withstanding those challenges, right up to the Supreme Court. So that's all I would say, other than the other thing to say is the market has moved. There are more self-insured employers now than there were 20 years ago, 10 years ago. And so it's a bigger factor in calculations of what can you do to influence the market than it ever was before. And so if you're a Department of Insurance commissioner or regulator, your influence over the market has diminished in the last 20 years because a larger and larger percentage of the market is going to self-insured.
Lori, you had a question. Lori, I think you're on mute.
So, yeah, so Maryland and Hawaii basically have the same thing as I see it with the 50% coverage.
No, different, very different waivers.
One is premium and one is total.
One has to do with what you can impose on employers. So in Hawaii's case, they were able to impose on employers a condition that they, if I remember it correctly, that they pay 50% of the premium for certain employees. So that was an employer mandate, essentially, way in advance of the ACA employer mandate. So employer mandate. We can tell employers what they have to pay towards employee coverage. That was a federal law change specific to Hawaii. In Maryland's case, there was a specific federal law that said you can require that all provide that I don't know. I would have to look back at how they phrased it, but basically it was that you require Medicare, Medicaid, and commercial insurers to pay the same rate to hospitals in Maryland.
And that was through permission from CMS.
And that's kind of a
Medicare.
global budget
Well,
thing
it was
too.
continued through permission for CMS, but it was a federal law.
Yeah.
I mean,
Right.
Barbara Boxer got a law passed that said this was permissible. That's where, as you think about your plan, there's an important confluence of what's permissible, what will our congressional and state delegation support, and what could we get through Congress? Because ultimately, if you wanted to implement the fullness of the plan you're working on, you would probably need a congressional action.
I would just add to the ERISA discussion, we'll send it out to you, but the task force had a very extensive opinion by some national legal experts on ERISA in a way to develop a plan which they felt would be challenged in court because every ERISA piece is challenged, but felt that it had a strong chance of surviving that ERISA challenge. And we'll get that report out to everybody. It's about an 80-page report and well worth the read. Jenny, can we make a note to get that out to folks?
I did, yes.
Thanks.
Next slide, Katie. So the waiver processes take time just to be, even if you're just going to do what's pretty commonly done Medicaid waivers, there's multiple steps, and we had outlined them here and in your draft proposal, but they, you have to kind of talk to them about the feds about your concept of what you want to accomplish and have it all sort of narratively written out. And you also then have to create budget neutrality calculations to prove to the state, to the feds, that the state's not going to be spending more of the federal dollars than they would if they weren't doing whatever innovation they're asking for. And other required data is required. And then you sit down and have conversations, and it's a multi-layer. There's the actual Center for Medicare and Medicaid Services conversations you have. There's also the actuary who looks to see if at all the numbers look good. There's the Office of Management and Budget that has to sign off on that. And in the past, a lot of my experience and others is it usually requires some approval by the White House and potentially congressional delegation support, usually to help advocate for it. And then there's a detailed terms and conditions document that says, yes, you can waive this, that, or the other thing. And then they go, and that's sort of negotiated to make sure that the language is the way the state and the feds are both thinking about it. And they're all thinking about it in the same page. It's kind of like a contract with the state about what the changes would be. So it's a pretty well established process for the Medicaid side of things. Next step, next slide. I don't know, Anya, if you want to pick up here, but there's some additional negotiations that to get full approval that you would probably have to think about beyond the Medicaid process, and that would be conversations with, it's another acronym, CISIO, which is the Center for Consumer Information and Insurance Oversight, that oversees the Affordable Care Act marketplaces. So you would need to have a conversation there. If you're talking about Medicare funds, then it would be CMMI that we mentioned before, that has the approval potentially of, if you wanted to try to talk to them about either getting into the AHEAD model or doing something different there. Approval from Department of Labor potentially to compel, would you want to, if you were going to compel employers to participate in the universal health plan? Approval from office and management or Congress to spend the employer tax deductions is a whole nother area that would need to be explored. And then the ERISA you would be dealing with the Federal Department of Labor.
Yeah. So I would just add, yeah, these were complex and unpredictable negotiations. You're trying to gather up all these revenue sources and get some control over them. And OMB will have ultimate control over and will anything that you negotiate around Medicaid or Medicare will go through OMB. And so that will have an impact on what you can do. And there isn't there's no roadmap for doing this. We can what we've listed here are kind of stopping points, speed bumps, but there is no real roadmap because no state has done this successfully. I worked on this in Vermont. We got to a certain extent, to a certain point, but I wouldn't say we got very far down the line. Other than, you know, a federal agency saying, like, are you insane? What are you talking about? So it would require a lot of both technical and political input. So your congressional delegation would have to say, we really agree with this, and we want to push this either legislatively or administratively. But it's not an easy course. That's all I'll say.
And next slide. And on a federal level, there have been some attempts to try to smooth that road. There's been a Medicare for All Act. It was introduced back as long ago as 2003, been repackaged multiple times. It was introduced into the last Congress. We haven't seen it. It was also introduced again, which I think applies to this Congress, but it really builds upon and expands Medicare to every person in the U.S. And you've probably heard Senator Sanders and others talk about this, and it would include both acute care and long-term care. The other legislation that's been discussed, it was introduced first in the 117th Congress and reintroduced in the 118th in partnership with our own Oregon Senator, Senator Merkley, which is the State-Based Universal Health Care Act. There was a House version also introduced. We haven't seen a new version in the 119th Congress at this point yet. It creates a new waiver, sort of a super mega waiver option of multiple federal statutes to allow states to implement their own universal health care plan for at least 95% of their residents. And it must have a 10-year fiscal year budget. And again, as per everything else, it would need to demonstrate that the feds wouldn't be spending more money than they are currently for your state. But so, I mean, that would potentially smooth things quite a bit, but we are not sure what its future is. It's just been introduced. So in summary, there is waivers under the Section 1115 for the Medicaid dollars that potentially could be negotiated. The Section 1915 would need to be looked at closely to see how that would interact with the Universal Health Plan. If you're trying to maintain some of those home and community-based services, you'd probably want to keep the 1915 Bs and Cs. And I think the 1915B about managed care is kind of up for how the plan will be structured. The ACA Section 1332 would probably need to be looked at and examined in terms of what you're going to do with the bridge plan participants and how those subsidy dollars could potentially fuel the universal health plan. And as we've probably overemphasized a bit, but Medicare is going to be hard. You have to come up with, some detailed discussions with the feds, particularly through the Centers for Medicare and Medicare Innovation, and or try to get into the AHEAD model, which might make it more be a model they already have in place. But it's not as necessarily as easy of a path to figure out how to do it. And then the ERISA we've talked about, you'll have the paper to read more detail about that on how to avoid an ERISA challenge. And then this possible super waiver authority would certainly make it a little smoother, but it does have an uncertain future at this point. So on all that cheery news, I'll open it up and see if folks have questions.
Yeah, questions. Lori.
So I guess what I'm hearing is we don't want to change the amount of money per person, right? So as I'm thinking that we might end up changing the numbers of people as you expand coverage to different segments of our residents, that would increase the cost.
Well, I think the question is whether what you would want to do is try to bring in the money that's currently being spent on Medicaid patients and potentially Medicare enrollees as well, and apply it to those populations, so that your costs overall. But I don't think the federal government will allow us to put Medicaid dollars, say, to pay for my universal health coverage, but they would probably allow you to apply that money towards those who are Medicaid eligible. Does that make sense?
Yeah.
Other questions? Judy.
Thank you. Apologies for being off camera. I'm having massive technical issues this afternoon. Just a question, and I don't know, Bruce, if you know this answer or if anyone on the committee, has there been communication between the Universal Health Plan Governing Board or staff and Jeff Merkley's office? I'm really curious about the state of this state-based Universal Healthcare Act.
Not to my knowledge.
No, staff hasn't communicated.
Let's go.
Yeah, we can certainly contact Senator Merkley's office for some more info. And it might be worthwhile at some point in the future to just brief his staff about the work the committee's doing. Other questions? Well, thank you, Anya and Janine. That was great. They included some great references for folks. And I guess just to sort of close the circle, I think you can see from this that it's, as stated, a complex area. It's sort of a bit of a chicken and egg in terms of we need to have a plan to determine what we need waived. You can't get waivers without a plan. So at this point, I think the board has decided that they're moving forward with a plan to include everybody, and as that solidifies, we'll then need to come back and figure out a waiver strategy. That the politics may be different, the administration may be different. We'll see, but that's sort of where we're heading. Paula, and then Anne.
Yeah, I was just going to say, Bruce, that It does seem a lot and a little overwhelming, but I do appreciate the breakout and description of each of those so that we can at least know what it is that we're having to deal with. So appreciate that.
Thanks. Anne?
Yeah, my questions are just matters of curiosity. In terms of negotiating all those waivers, the allocation of resources isn't clear. So I'm kind of curious about how we would manage that. It's identified as a barrier, so it should be in our risk documents, but I think it also impacts the work streams, you know, who might be involved in that. Do we have to capture that just to give the board an estimate, or is this premature?
I'd say it's a little premature at this
Okay.
point. We need to get a little further along with the work of the other groups.
Okay, good. And then my other question is, the other states that I've lived in, a fairly sizable amount of healthcare funding came through the military. Is that true of Oregon as well? Like TRICARE or managed care with the Veterans Administration?
I'll just pitch in as from going through that with the Finance and Revenue Committee. It's a small slice in Oregon.
Okay.
And in the past, the task force sort of kept it out of their plan at that point because it was complex. But we don't have the big bases and that sort of thing that some other states do.
Thank you.
Anya, you up, the hand is down. Other questions, comments? Okay, so it is 10 of 2. My sense, however, is that we're not going to need a full hour for the rest of the agenda. So if folks are okay, I think we could continue on and probably end a little early, or happy to take a break now. It's is there a strong feeling to take a break right now? If there is, raise your hands. Okay. We're gonna keep going. And I think that the next agenda item is really the review of that draft report. And I think you all got the draft report, and I think it was a really great compilation and resource to us that Anya and Janine have put together. And it outlined, very much followed the outline of today's presentation. And I think the question for the group is, are there things that are missing in that you'd like to see? And any comments about that? Anything you think shouldn't be there? Anything you feel needs additional information? Anything that we don't have that you would like to see? We'd love for you to let us know. Anne, you're on mute.
Well, dang. Maybe we can do page by page because my comment begins on page 3.
That'd be great. Jenny, can you get that up there?
I'm sure Katie is working on it right now.
Katie. No sooner said than done. So let's scroll down to page 3. Okay, Anne.
Yeah, mine was just a really minor point. 4th paragraph down, they're talking about consumer protections and quality. The way that's done in some places is just to reaffirm or include a really simple statement like we uh, we recommend abiding by CMS deemed status accreditation standards for quality and consumer protection. And what that does is puts the that puts the burden onto the accrediting bodies, which continually update and have inspections and everything else like that.
Great.
In other words, we don't have to take it on as a burden of the state. We can delegate it.
Any thoughts about that from anybody?
I do think that we put these in, that would be part of your discussions with Medicaid to get the waiver, that you would abide by their regulations. However you decide to do it, but it was just more an acknowledgement that you would have to consider those and be ready to defend that you would be satisfying the Fed's requirements.
And my point of view is it's actually stronger if you make a statement saying you're committed to quality of care and that this is the mechanism for how that will be assured is done. Centers for Medicare and Medicaid, that's a value that they pushed for 20 years. And I think it's just helpful to make a statement to that intent.
Yeah, we can definitely get that in there. I wonder whether it would just fit best as a summary and recommendation as opposed to putting it on page 3.
I agree. I think just list it as this is definitely what we're doing
Okay.
with all the other recommendations. That's appropriate.
I have captured that and will make notes.
Thank you very much.
We need to scroll any further, Anne? Or anybody else? Go ahead, Anne.
Yeah, sorry.
Oh, this is great. This is why
A
we're
lot of this is just me wondering, just being curious. There, just in terms of the structure of this document, there's some barriers identified, there's some potential policies, and there's some recommendations. I would only suggest, as you just mentioned, that those blocks be carved out with that description of what the content is.
okay. So just make that clear, those 3 sections.
Yes, exactly. Thank you.
Paul.
Yeah, I have feedback related to the AHEAD program. Kind of starts on page 6, mostly on page 7. Is it possible to get more information about what the first cohort plans to, because the first activity isn't until 2026 for actually trying to implement that. I'm just curious if we have any more information on what they're actually doing.
I believe that's in the link I gave you on the resources page, takes you to the AHEAD pages if they're still there in this at CMS, and you can look up cohort 1 to what they're doing. Most of them are just working on their plans at this point, but it's in the link in the resources.
Yeah,
the
but
okay,
to your
perfect.
point, like what's going on, we don't know. These states have signed up for this model. We don't actually know, like the model is really ill-defined. And we don't know if it will survive under the current administration. So I think there's a big question mark around it.
I was in Hawaii when they were just doing their first site visit, CMMI, to Hawaii's to look at what they were doing. And so even though they're cohort 2, there was a delay before they've even, so they're just barely, I know, starting at this point. So
And maybe just for completeness, we could put that resource, that link in
we could just
the
embed,
document.
yeah, we could embed the link.
Yeah.
Thank you. I think I was looking in the resources on the PowerPoint presentation instead of the actual draft. I found it. Thank you for that link.
Other thoughts? Doug?
Yes, Bruce, this is a question from my experience. We're talking about a public corporation, not-for-profit public corporation. And, you know, you mentioned that they provide services that are provided by other, you know, entities out in the private world, so to speak. What they deal with in the private world around this topic is something called risk-based capital and insurance risk. This is an insurance activity in the private sector. They have very stringent rules about reserves, financial reserves they have to maintain to keep their license. Are we, you know, that's my thinking from my experience. You understand that, Bruce, but how does that translate to this?
Great question, Doug. And I was going to bring this up. Let me see if this answers it. I think one of the key pieces of work of this committee, probably the biggest foundation, is going to be how to administratively set up this universal plan. Will there be organizations that take risk and will need risk-based capital? How does the state insure against its own risk? How do we actually set up the administration of what's going to be a $50 billion plan taking care of over 4 million people? We're just getting our consultants lined up who will help us with this. So I think those issues we will be grappling with in the months to come once we get some expertise on board. But we've just been covering some of the topics like waivers and public corporations while we're waiting for those experts to get on board. And I think that's going to be the key work of this group. Does that make sense?
Yes. Iterative process.
Yeah. Other thoughts? Okay, we'll make those changes in that. You know, we have no we have no oral public comment today, but we have some written comment which came from John Santa. So I hope everybody had an opportunity to read that. Any other final reflections or thoughts from folks? Jenny, what have I missed?
I don't think you've missed anything, but I will go over just to make sure that I've captured for everyone the changes that were recommended to the document, which included adding a summary recommendation about using CMS standards for accreditation, adding headers to delineate the sections in terms of how it was phrased in the meeting. And I'm sorry I didn't capture those, but I will go back and find them. And then finally, embedding the AHEAD program link into the document in that section. And so we will put that together, bring it back to you at the next meeting. In the next meeting, we are going to start talking about putting together a fund in the state treasury. Bruce, did you want to add anything about that?
No, just that like everything, you start to learn, and when you do this, we had an initial meeting with the deputy treasurer yesterday or the day before, and there's actually a lot of things to consider in setting up a fund in the treasury that I was totally unaware of. So it's going to be an interesting discussion. Much
And
like we learned a lot about public corporations.
And the only other thing is, I just want to remind the committee that we'll be moving forward the public corporations proposal to the board at their March 20th meeting. And so that document will be posted with the other board documents for that meeting. And then we'll follow up in next month's operations meeting to let you know what feedback we got from the board about that document.
Great. Thanks, Jenny. Thanks, Katie. Thanks to everybody on the committee. Really appreciate your input and your work. And we will be in touch and we'll see you. And thanks to Anya and Janine for the great work that they put together. And we will see you all in a month. Bye-bye.